All right, now we're going to talk about what happens after first-line therapy. And Carlos, why don't you take it away and just talk about, when do you start thinking about second-line therapy? What's resistance?
Well, I think that the resistance raises a very important point in the management of kidney cancer. And I think is one of the major unmet needs in this area. We do not understand the mechanism of resistance in order to make rational choices in our second-line therapy. So that's a very important aspect of what we have been doing in clinical research. So that's an initial concept that I pose to all of you. The second concept is that the definition of progression when we use targeted agents is not necessarily the same or as easy as we have been used to with the progression that we obtain with chemotherapy in oncology in general. Chemotherapy progression has been clearly established in clinical practice and in clinical research with the RECIST criteria that apply in general to what the benefit for the treatment with chemotherapy is in tumors in general. However, in the targeted area, we have been finding that some patients do not necessarily apply the RECIST criteria as properly as we would like it. So there are patients that sometimes do continue deriving benefit even though the criteria, radiologic criteria of progression are met. So we still are struggling at finding out exactly what the best way of dealing with this is. And I guess my recommendation or my opinion in that regard is that we need to be very careful and recognize that there are some patients that while still benefiting from therapy may actually have X-rays or CT scans with some degree of progression. And what we all have been doing is that if clinical benefit is there, we tend to continue with the targeted agents. That sometimes, hopefully that's what's happening, the rate of progression seems to be lower than if we essentially remove the drug from the clinical setting. So I think that this is a challenge for all of us, and we need to perform more trials in order to devise this. Later we'll talk about immunotherapy, and the same thing essentially will happen in that arena.
Mm-hmm. I entirely agree with that. I think the one other influence on us is availability of other lines of treatment.
Definitely.
So it depends on where you are in the world, but if you've got very limited access to subsequent treatments, obviously you have no choice but to tease out as much benefit from your first line of treatment before switching. Mm-hmm. And so inevitably we're influenced by what reimbursement decisions are taken locally, but also what trials you have available.
Yeah, and nevertheless, as we are not curing anybody with kidney cancer, making the best of every line of therapy, okay, probably prolonging some degree of control of the disease is certainly a good objective.
So, Danny, I would like to ask Paul a question. Paul, you mentioned that in UK you only have 2 lines. You can just use 2 drugs. Which one you start with, it's up to you, between pazopanib or sunitinib. You have axitinib and everolimus for second line, but you cannot use them more than once, each of these 4. So what about the concept? I mean, Danny, you're aware, we're all aware of the data of re-challenge and reusing the drug that you, so in other words, if you use, for example, sunitinib first, and then you went to everolimus, and then the patient progressed, can you go back and re-challenge with sunitinib? Because obviously there is data published in Cancer by the Americans showing that this strategy does work for some patients. And when you don't have other drugs you could use except those 2, it makes perfect sense to try again to re-challenge that patient with a drug that you, especially in clear cell RCC, where we know VEGF is the driver.
Or go on a clinical trial.
No,
if there is no clinical trial.
Mm-hmm. No, this is where there's a gap between what makes clinical sense and what the reimbursement decisions are often based upon. So as a kidney cancer doctor, I'm in no doubt that sequential use of and sometimes revisiting TKIs, it makes sense. And I have a cohort of patients who have had significant benefit from that. However, the reality is that in my world, The NHS makes decisions about what's available, and we're limited by that, which means that the vast majority of my patients who have multiple lines of treatment do so because they take part in clinical trials.
Sure, sure. Danny, I think the way I look at the question of, second line, is the patient sensitive to a first-line VEGF-R TKI or not? Mm-hmm. And I think, as we all know, there is about 20-30% of patients who are outright refractory. So they're not going to respond to any VEGF-R TKI. Those patients pose a really challenge, because as you published from your IMDC data, if they did not respond to a first-line VEGF-R TKI, they're unlikely to respond to another VEGF-R TKI or an mTOR. Changing tracks doesn't seem to really benefit. So there's something inherent about the biology of RCC that if they progress right through your best first-line VEGF-R TKI, it's a challenge to. So I think we will be talking about immunotherapy later, and maybe these are the patients who would be best treated with a novel agent rather than put them through the sequence of a VEGF-R TKI and mTOR inhibitors.
But again, you're raising an important point in that regard, in the sense that I feel that the lack of rationale, because we have not been biopsying these patients, we have not been collecting or analyzing the blood for tumor circulating DNA in order to find out what are the new mutations, what are the new molecular changes that actually happen and that may be responsible for the resistance, like we have been doing in other diseases. I think we are, even though we have a number of different alternatives, we have not been able to sequence them in the best way using a rational approach. Because it's a new diagnosis. How I'm going to decide on the treatment on second line based on a biopsy that was performed 4 or 5 years ago, even longer than that.